You're listening to Conversations with Chanda, a podcast that unpacks the community's grittiest, most vexing problems, hosted by Chanda Smith Baker. This episode is supported by the African American Leadership Forum.
Hello, I am so grateful for you spending time with me and joining Conversations with Chanda. I would love it if you could just introduce yourself to our listeners and let them know who you are.
Thank you so much, Chanda, for this invitation. It's a privilege to be here. My name is Rahel Nardos. I am a mom. I have 2 kids. I'm a wife. I am an associate professor in urogynecology at the University of Minnesota. And I'm also the director of global women's health at the Center for Global Health and Social Responsibility at the University of Minnesota.
And how long have you been here in the Twin Cities?
Almost 4 years. We moved here from Portland, Oregon in the summer of 2020. Yeah.
You chose to come here in the summer of 2020, which was a really complicated time for our city and certainly for health. What did you learn about us?
Well, both me and my husband were recruited by the University of Minnesota to come here. My husband is actually from Minnesota. So, it's kind of, his dream to be back home at some point in our life. And, but like you said, it was a pretty difficult time to move in the summer of 2020. That was the time of George Floyd. It was right after the pandemic, and we're still kind of figuring out our life with COVID. And we were moving with 2 kids. My son was starting 10th grade. So really tough time to move into a place where everything was virtual. So it was very difficult to establish a community right away, especially when you're a teenager. And my daughter I think she was at that time going to grade 5, if I remember right. God, it's been a long time. And then I was starting a new job. I've been in the same kind of place for a long time before moving here, starting a new leadership role, new clinical practice, and a new environment. So yeah, it was I would say it took a while for us to adjust. And of course, with the virtual environment, you don't really get to meet people much, right? And in the clinical work, at least I get to meet the patients. I take care of patients. So I was very grateful I actually get to go into work. But half of my job was virtual. And I think it's really hard to make connections with people in a new environment when you're not there in person.
Mm-hmm. We've had a number of conversations on this podcast and certainly in community broadly on people that are looking at sort of inflection points and transitions in their own careers. Was there any, you stated that you were at the place that you were at previously for a long period of time. How did you know that it was time for a transition, or did you know, or was it just a family decision? Like, how did you know?
For this particular transition, it was more of a family decision. My husband, I know, has always wanted to be in Minnesota. I mean, he's from Minnesota. His parents lived here, and but we had kind of not explored too much because personally, I was very nervous about the weather. And I'm from Ethiopia. I grew up in Ethiopia. I don't like very cold weather. So, and then we really loved Portland, Oregon, and we had a nice community. We loved our jobs. So for us, we were very comfortable there. But we had this big opportunity to expand our professional life for both of us. My husband currently is a co-director for the MIDB, which is the big institute, as you know, for the developing brain at the University of Minnesota. And I also had the opportunity to grow my international work because I do a lot of global women's health work and to have a bigger leadership role and a supportive environment at the University of Minnesota, which I knew would really scale up the impact that I wanted to make on the ground with our partners. So I also have family here. My brothers, my aunts, my uncles, we actually have more family here than my husband, who's from Minnesota.
Oh, wow. Mm-hmm.
So there was another incentive for me to consider coming here to get to know our family better here, and for the kids to get to know their aunts and uncles. So that was the big transition decision. So a few things together,
I love it.
Yeah.
So what inspired you to sort of take this career path that you have?
Yeah, that's a great question. I mean, I feel like a lot of my life has been, I would say, kind of one step at a time. My experience at this moment leading to the next moment, right? I grew up in Ethiopia. I came to the US as a scholarship student, college. And, I grew up in Ethiopia during the communist regime, where the country was always in conflict, and resources were very limited. As a child, I used to get sick a lot, and your options for healthcare were mostly the government hospitals, where you would go if you needed to be seen that day. You have to stand in line all day so that someone can see you at the end of the day. I mean, I didn't have a pediatrician. None of these things that we take for granted here. And so I grew up seeing how hard it is to provide quality and safe care, healthcare. And so I think that idea of wanting to go into medicine and taking care of patients was always in me growing up, even though I didn't really know it. So when I came to the US, I received a scholarship to go to Franklin and Marshall College. Very fortunate at that time. That was right when our communist government was overthrown by a new government. And I actually didn't know what my future was going to hold at that time. So that was very fortuitous opportunity. So I traveled here actually by myself, went to college. Some of my family was already in Minneapolis, but I went to college in Pennsylvania. And there I started thinking deeply about what I would like to do. And I think as a woman, and having witnessed some of the disparities in women's healthcare, especially in countries like Ethiopia, where I grew up, especially in rural communities, I was always thinking about what can I do to advance the health of women, both in the U.S., disadvantaged people in the U.S., but also in a global context in countries like where I grew up. And so I think that's what got me to consider medicine and to get into medical school, and then eventually residency training in OBGYN, and then fellowship training in urogynecology. I've been in school for a long time.
Bless you. We need you. We need you for sure.
Yeah.
So as I'm listening sort of to your life story and thinking about really what you grew up around, and talking about sort of the political context and the social economic, continuum, right? So when you came here, were you surprised by the healthcare? Like, did you anticipate something as you were going through that was like, were you surprised in any way?
I mean, there were so many things that surprised me about America, right? The first 4 years in college, I definitely was kind of lost in a way, adjusting to a new life in America. A lot of differences, obviously. But in the medical system, I was just amazed at, it's kind of two-faced, I would say. I was amazed by, for example, even simple things like how clean the hospitals were and how bright the hospitals were. Those weren't the hospitals where I grew up, and how many doctors there were, and the nurses, and everything, like the facility, the resources that are at our disposal, the technology. So that's starkly different from the low resource environment where I grew up. I always thought hospitals were places where people went to die or to get sicker. They smelled really terrible. At least that was my experience growing up. Things have changed now a lot, but so that was really fascinating to me. But at the same time, there were aspects of my upbringing and concepts of healing that were really strong, like in terms of how you, for example, if I got sick, my mom and her community of women in the neighborhood, everybody came to take care of you. They brought you things. They have some spiritual healing practices and things that they would do for you that was really nurturing, to the soul. And part of healing is not just the medicine you take from the doctor, but it's the care you get from the community and from the people. And I feel like that aspect of the healthcare and healing is lagging behind in Western cultures. And I'm not seeing that as much. It's very, we tend to really rely more on kind of medicalized kind of environment as opposed to some of the other parts of healing. So I'm always like in this in-between place when I think of taking care of patients and what they need from us. I think my background as growing up in that environment in a different culture and that mindset and view really shapes what I think really healing is. And I actually have come to think, more recently through meditation and mindfulness and learning more about other philosophies of healing, like the Buddhist philosophy of healing, that maybe our job is not to fix people. Our job as physicians is to reduce the suffering of people. That doesn't necessarily mean that we need to have the solution for every problem. It just means being with them and listening and help, seeing them and letting them know that you're there with them. And I feel like half of the healing is that. And that's the part that we're not doing a good job, I think, in the West teaching.
When I think about the doctor, and you and I have had other conversations where, you go in and you better have your talking points ready because you got a limited amount of time.
Yeah.
To tell the doctor or the practitioner what you've got going on. And it actually doesn't feel that way. It feels like I've got to be able to articulate it. There's no real inquiry around what's happening. How are these perspectives shaping how you're delivering care here?
Yeah, it's for me, it's been a lifelong learning, honestly. And that's actually one of my big philosophies in leadership or in any kind of when I'm trying to teach young doctors. I have students, residents who work with me. If they have to take one thing, I'm always telling them, being open to learn and being humble and being, not going into that exam room or visit with a patient already with your mind set on what this patient needs. I think for me, the patient knows their body more than anybody else. They're with their body 24/7, while I'm seeing them for 15, 20 minutes. So I should never think that I know more about them than they do. And also, how can I bring the stories out in a way that's going to help both of us figure out what's going on? Like for me, that's like the most important part of the doctor-patient encounter is that story, right? And not like what I'm going to do next or how I'm going to fix this problem, but like, let's get to the story first. Mm-hmm. And you're right. I mean, our visit times are so limited. So I'm actually kind of, and so the system is not really built for us to provide that kind of care, unfortunately. But I feel like we still have some power within that constraint. So for me, for example, I'm very fortunate. I work in the area of urogynecology where most of the patients are suffering from, incontinence, prolapse, things that are more chronic conditions and affect quality of life. They're not like life and death situations. They're not urgent. So I remind myself every day, okay, there's no urgency in getting to a diagnosis and fixing this problem. The first step is just the story. So when I first meet a patient, I have to be okay with just getting to know the patient on that first visit. And I will tell the patient, we may not have a solution for you today, but we'll get to that solution. But I need to know exactly what's going on first, and then kind of pacing that interaction so that by the time we get to a diagnosis and a solution, it's very much formed by what the patient feels and thinks is important to them. And also the patient is more likely to be on board with the plan we make together. Because I can prescribe medication and tell the patient what to do. They will not do it when they go home if they did not understand why and all of that thing. So, I think it's a very worthwhile investment to establish that trust and story first. So that's kind of my philosophy of care. It's kind of slow medicine,
Slow medicine. When I think about even how I was raised around thinking about hospitals, and your story of thinking about hospitals as a place to go to die brought up to me an incident, and I've shared this before on the podcast, but that I had come across a scene where a young man had gotten shot. And I pulled around the corner, and there was these, teenage kids, young teenagers, boys, sort of they had witnessed this, and they didn't seem to be visibly upset.
Mm.
But I was trying to get them away from the scene. And they're just sort of like, oh my God, this happened, until the ambulance pulled up.
Mm.
And when the ambulance came, one of the little ones started to cry. And I said, well, why are you crying? And he said, because they're taking them to the place where people die. And I remember thinking the disconnection between what had occurred and how people's environment, culture, experience shape what is happening in healthcare, around wellness, all of that. I think that was the most clear example of it for me that really informed a couple of decisions that I had later when I started working on North Market and some other pieces on how do we integrate health and wellness into community?
Mm.
How do we understand the narratives that exist within communities so that we know what the right strategies to deploy are? And so how do cultural sort of beliefs and norms factor into what you're seeing in terms of healthcare, or even healthcare disparity?
Yeah, that's fantastic. I mean, first off, it just kind of breaks my heart to hear that story, Chanda, because, this is also a thing that we experience in a lot of countries where, for example, with maternal health, in rural communities, a lot of women labor and have babies at home. And part of it is, lack of access to obstetric care, but part of it is the mistrust of the healthcare communities. And also, by the time they make it to the hospitals, usually they're in very desperate time, right? Like very in critical situations. And of course, their chances of dying at that point is pretty high. And then when they do die, then that builds that same fear and distrust of hospitals. That's a place where women go to die when they have their babies, right? So it kind of builds in that same kind of cyclic narrative then builds up, And why did that even happen in the first place? It's because, these women weren't accessing the care when they needed to access the care, well in advance, and they didn't feel like they could trust the healthcare system. So that's definitely, I mean, we absolutely need to work on building that trust with communities and understanding like where they're coming from and why this is happening. I think we're still way, way behind on that. And that's the kind of like real work that needs to be done. A good example I can think of in my own practice here, for example, I'm I'm beginning to see a lot of women from immigrant communities with pelvic floor conditions like bladder pain, pelvic pain, overactive bladder, incontinence, and stuff coming to see me. And there are certain communities, immigrant communities, for example, who absolutely do not want to have a pelvic exam, for example, even though I'm a pelvic floor specialist. So they are referred to me for pelvic floor conditions. So, like, generally, it's understood by almost all my patients who come to see me that I will do a pelvic exam. But there are certain groups of women, especially women with a lot of pelvic trauma from cultural practices or other things, who absolutely would not have a pelvic exam. And that really compromises the care that I can provide to them. And sometimes I'm able to build slow trust with them where I won't do the exam that day. I will talk to them. They will get to know me. And then eventually they might come back for that. But there's a huge and when I ask questions, a lot of them would say when they first moved to America as immigrants, they had a really bad experience with pelvic exam, or there's usually, if you ask more, a lot of those people who are hesitant, it's because of personal experiences of people not communicating to them what they're doing, not being gentle with them, not respecting the cultural barriers and all of those things. And that can really impact the care that we provide going forward, like even things like cervical cancer screening, like you can't do pap smears, you can't do. So, I think that's stuff that we need to work on.
Yeah, that's helpful from a cultural context. Are there other sort of barriers that you're seeing or opportunities that you're seeing in terms of sort of the unique challenges that women might be facing in terms of accessing healthcare? So one is sort of the cultural experience, trauma, norms, like maybe people coming from here not understanding. Are there other challenges that you see that we should be thinking about as we're looking at addressing women's health and women's health disparity?
Yeah, I mean, that's a good question. I think just in general, if you take women in general, I think some of the challenges that I'm seeing are, for example, I take care of a lot of postmenopausal women. A lot of the pelvic floor conditions I treat get worse with age, with menopause. So there's this underlying assumption that, first off, there's very little understanding what the impact of menopause is on the body, on the mind, on the body. In my situation, a lot of the conditions I treat, like women getting urinary tract infections frequently, or overactive bladder with urinary urgency frequency, or increased risk of urinary incontinence, they're actually very much related to menopausal issues. Hormonal lack of hormones can actually contribute to a lot of those things. But there's this tendency, number one, that women are told that these are all things that happen as you age, and just it's part of normal aging, and so they don't always seek care for them, right? So that's a problem. These are also conditions that are usually kind of taboo to discuss. A lot of women don't feel comfortable saying they're having trouble with these things, and so if they're not bringing it up with their healthcare professionals, obviously they wouldn't even know people like myself exist, urogynecologists who focus on these issues, and that there are solutions. You don't have to live with this condition. So part of it is just lack of understanding. And I actually personally blame myself and my own community of healthcare professionals for not doing enough to communicate these things in a public forum. Like this podcast is one of my very first podcasts ever, right? As healthcare professionals, we tend to write about these things on our scientific journals, or, we talk to each other, we teach each other within the medical community. And I teach people one-on-one to my patients, but I don't always routinely communicate with the public about this, or, I don't know, make it available publicly, good information for women. So this is something I think we all need to work on. So that's a big barrier, I think.
Yeah. And I mean, I feel like I'm pretty much in the know about a lot of things, right? Like for a lot of topics. I talk with a lot of people by way of this podcast and other ways. And when I met you, I'm like, wait, what kind of doctor? What do you do? And I think I've even shared with you a couple of stories of friends. And of course, I mean, the narrative was very much like, as you age, these things are happening. Or a friend had said something to me, and I'm like, oh my gosh, I know what this is because I've had this conversation with you. And so, when we're looking at taking control of our health, which is something that many of us are just coming into practice, right? What are things that we should be thinking about, particularly women, on how we can be more empowered? So a piece of it is certainly education, but how do you know where to go if you don't even know it's a thing?
Yeah. I mean, the good news is, if you are bothered by something like this, you can always bring it. Part of the challenge is just even knowing that this is not normal and then just bringing it up during your routine primary care visit. Because most primary care doctors will know, like if you tell them about these conditions, they will make the referral to specialists. They will tell you about pelvic floor physical therapists who can actually help you with some of these conditions. So part of it is like knowing to speak up and bring it up and not thinking that this is something that you just should tolerate, So that's where the public awareness is really helpful through people like you, doing this podcast, for example, or writing on a newspaper or, whatever we do to get this word out that this is not normal and you can seek care and then your primary care can direct you. I would say that's the biggest barrier that I see. But of course, if you are come from communities like the immigrant communities that I talked about, access to medical care might be much harder, for many different reasons. It could be transportation, insurance, cultural barriers, and not being able to speak about this kind of private matter in public. They have a lot more other kind of barriers as well. And also just health literacy, a lot of women I see, they can go online and read about these conditions. And by the time they come to see me, they have some idea of what's going on. But if you're not somebody who's good with going online and researching and reading, you don't understand the language, you don't actually know what's going on, right? So you don't know where to start. So health literacy is a big one. This actually brings me to one of the things that we're doing now, a small project that we're working on. So I'm collaborating with this community participatory action research group in Minneapolis that's actually based out of the Cook Clinic, the Community University Healthcare Clinic. They're called Solamo. And one of the things what I noticed when a lot of the immigrant women who don't speak English come to see me, they usually bring their girls with them, kind of like their advocate and their navigator. And they serve this role of like, they're the ones who make their appointments. They're the ones who like are the second ear to listen. Sometimes they're the ones who are interpreting because they don't want a male interpreter or another interpreter because they're talking about a private matter. Nonetheless, what I noticed is what a big role these young people play. And I started thinking, wow, they're trusted members of their community. They're already playing a navigation role, a healthcare navigation role. I wonder what their experience is like. Like, I wonder where their barriers are as they're bridging this care gap for their families and where the burden is. Like, they're young people. Like, I know they have their own life and being in charge of navigating health for your mother or your aunt or your grandma, that must be an additional burden. And also, like, where are they struggling when they try to communicate with healthcare professionals or when they're trying to navigate and see who their mom should see? Mm-hmm. So we're doing this focus group study right now. We recruited women and their children who served as their navigators, as well as some of the community leaders. We're looking at Ethiopian, Somali, and Latino communities. Very small study, but we're kind of having this deep conversations with them to understand their experiences, where they see the barriers to access to care are. And I'm really excited about the possibility of learning where we can help these young people to be better at what they do already so well. Can they be a trust building bridge for us? Could this be an opportunity to mentor them about healthcare so more of them would be interested in coming into healthcare? Could this be an opportunity for us to provide them with simple skills like communication skills or health literacy skills to do the work that they're already doing in a much better way, right? That's kind of my hope. How can we start creating those solutions?
Yeah, I love that. And you went to where I was thinking on sort of the pipeline into healthcare, and understanding that we have some big gaps that are happening right now on the side of pipelining folks into healthcare careers.
Mm-hmm.
For folks that have an interest in that, do you have other ideas or ways, or are you seeing barriers to why that is? Is it simply the affordability of college, or do you think it's more than that?
I mean, I think it's a big problem. It's fascinating because the need is so huge. You should see the faces on my patients, like when I walk into a room, and when they see I am East African like they are, if they happen to be from East Africa, or I'm Black, and it's very rare for them to see a specialist, especially. And you can see, I almost feel like part of the healing starts with that knowledge. Like they have
Oh,
a big
absolutely.
smile,
You got
they have
me.
a big smile on their face when I walk in, and they're like, "Oh my God, where are you from?" Um, and I feel like we need more people who look like the patients we are serving. It's a big issue, and I think but the barriers are so complex. I mean, I will tell you, like, just for myself, I was actively discouraged from going into medical school when I was a very good student in college. I was on a scholarship, I was an honor student, but at that time, as an international student, uh, almost all the state schools in America who are medical schools did not take international students, like unless you have a green card or citizenship. And the only schools that they told me would even consider remotely getting me in are the private schools, the Ivy League schools. They're very expensive. I was told I couldn't take loans because I'm an international. I need a green card, or, basically what was communicated to me, even though I had expressed my interest in medicine, was it's not a good path for you. And so it took me a couple of years to figure out how I could do it. And, I went through a lot of hard times during those 2 years. I almost got deported because I lost, I was going to lose my immigration status. And what ended up happening for me was, my uncle and his wife, who are here in Minnesota and have been here for a long time, decided to co-sign for me for a loan. And I had to take a private loan, and I couldn't qualify for federal loans. So it was higher interest rate. It was full loan. My school, I ended up going to Yale University for medicine, and they did not have financial program for any international students at that time. You know, things have probably changed since then. So the odds were very much against me. And I share that story with a lot of immigrant students who really want to do medicine, but they're very scared about all these things, to let them know that after all these years, I'm still paying loans, by the way, 20 years out, because that was a lot of loans I took and a lot of interest. But I'm doing the work I love. Like I'm exactly where I need to be doing the work that I love. I couldn't do anything differently in retrospect. And I tell them, if this is really your passion, this is what you want to do, despite all of these barriers, things can happen. And I like this analogy of water. That's always like my North Star, like be like water. I think it was Bruce Lee who said, be like water.
Yeah, yeah.
And it's like how you work around the rocks and the things and get, even though, water doesn't seem like a very strong thing, but it can work its way through cracks and through hard things. It can mold itself. It can, into the container that it is. And I feel like if that's really what you want to do, there are ways around the system, because the system is not really built for us necessarily, but I share my story to encourage people to get into that. So there are, obviously a lot of barriers like that.
Mhm.
Yeah.
I'm teaching at the Humphrey Institute right now. I have a student in a class, and I have, through other referrals, talked to international students that are worried about having not being able to continue their education and having to go back to their home countries
Mm-hmm.
because of the barriers that they're faced with. And I'm always in tune when sort of life is showing me where the disparities are, or the way in which we undermine our own intentionality in our country or in our city, right? That we are talking about how we need to pipeline people into these careers. We need to address the racial equity gaps and who's employed in these sectors. And yet we have pipelines of people that want to go through the process that are getting weeded out because of bureaucracy. And I'm continually trying to reconcile
Mm.
that, and trying to determine what role I have in that, if any.
Yeah. What is my actionable item? Because I mean, in the, I don't know, like mid-career, at some point, like after age 45, I got tired of hearing health equity just as like the right thing to say or do. And there are definite institutions that are trying, but I start seeing the discrepancy between what we say and what's actually really ingrained or embedded in the system that makes it hard to really do equitable work. I mean, this is true for healthcare.
Mm-hmm.
I mean, a good example, for example, like, patients who have very little, who need my assistance, for example, if they need to come to see me at the university hospital, they have to pay for parking right next door to my clinic. And that could by itself just be a barrier for them because that's not cheap, right? Simple things like that, like, can we change the way we're built here to make it easy to access? So there's a lot of systemic obstacles that make it hard. But at the same time, I feel like we all can do something.
Mm-hmm.
I mean, I'm not willing to just accept it, honestly. Like, I just feel like, what is it that I can do in my power to change it? Like there are like simple solutions for some of the barriers that we're facing that we as individuals can come up with and do. And that has been more of my focus in the last, few years of my career. And so every project that I work on, and engagement has been like this, coming up with solutions rather than just talking about them. I think we can all do that.
We can do that. What is exciting you the most about the work that you're doing right now?
Oh my God, like Chanda, just before I came to, like, the meeting I had before this meeting was on this app that we're building right now, in collaboration with the Backus Center for Spirituality and Healing at the University of Minnesota, our physical therapist, pelvic floor physical therapist, and our mental health, the psychologist, the women's health psychologist in our department.
Mm-hmm.
We're together working on this app to bring in mindfulness meditation for pelvic floor care, because a lot of my patients who have pelvic pain, bladder pain, overactive bladder, have a lot of stress and anxiety that either is triggering these problems or is aggravating it. And when you are stressed and anxious, you tend to hold tension in your body, and that tension translates into some of the symptoms. And so we're trying to create this 8-week course that people can just do on their own, that has the mindfulness meditations that they can do every day, but also some of the pelvic floor exercise videos that they can see, like what kind of body positioning can help relax the pelvic floor when they're stressed out, and some of the psychological kind of underpinnings of, managing stress and anxiety, and some of the behavioral interventions I talk to them about bladder health, like what are the things you should avoid drinking to be gentle on your bladder? What are some of the habits of, using the bathroom that can help you. So we're putting all of this together into an app, and we're working with app people at the university. So we finally like shot all the videos, and we're beginning to see this beautiful product potentially coming into being, like it's being born. That gets me really excited. I already have like 20 patients who have said they want to try this app when it's out because they want to be the guinea pigs. They want to see how well it works and give me some feedback on how to make it better. So like that, I'm very excited about that. And I have a few other projects internationally that I'm working on that I'm very excited. Again, very solution oriented stuff,
Yeah. Where does technology come into healthcare? Because it feels like even just watching your face light up, it feels like it's an opportunity for accessibility for people to have more agency around their own health. It is informative, but like, how do you see the integration of technology into healthcare?
I mean, yeah. I mean, first off, you also have to make it sure that it's accessible for everyone and not just for certain people who know how to do it or have access to it. So that's definitely, but for this particular app, for example, we're making it mobile friendly, meaning that you can access it wherever you are on your mobile, because people these days are on their phone all the time. So making it accessible. And there is now a precedence for if once we have this app and we kind of hopefully test it and make sure it actually works for the things that we want it to do, like you provide the evidence for its impact, then there is a possibility for some of this kind of behavioral interventions through self-paced apps to become part of the care model, where it can be recognized almost as a treatment and be prescribed by physicians, for example. So it doesn't have to be a pill. It can be this kind of app-based intervention that can be prescribed by providers and covered by insurance. So my dream in the long run is how can we make this kind of intervention that is self-empowering and kind of individualized to the patient to become part of the care that we provide. Integrating it into our health system.
Yeah. I think I remember you saying that you're a prescription or a pill last person, a doctor. Like you don't start with what is the prescription, but that's sort of a last solution. Do I remember this correctly from you?
Yeah. Drug companies probably would hate me because I'm probably the least medication prescribing urogynecologist in Minnesota, maybe. I like to optimize patients with all of these other things before I start medicine. The reason being, number one, like if you can actually manage your condition with, what you put in your body, with exercises that you do, with the habits you form, that's a much better way in the long run of sustained impact than medication. Obviously, medications have a place. Some of these medicines work really well, but they should never be first line if there are other non-medication-based interventions because they have side effects, right? And, at least in the bladder health area, the medications people don't stay on them for too long. Not a lot of people because of the fear, side effects, interactions, those kind of things. So, but, getting people motivated to do some of this other work, like physical therapy, pelvic floor physical therapy, that's not a quick fix. You have to go to them 8 to 8 weeks in a row to get better, and then you have to do the exercises regularly, make it part of your routine. And so it's easy for people to take shortcuts and be on medicine, but that's not usually how I like to approach it. So I like to work with them and take time. And then if they don't respond to those things, we always have the option of trying medicine or surgery or those things. Yeah.
Yeah. I know that we started out talking about your background and why you were recruited here, and like threaded throughout the conversation, we've talked about some of the women health issues that you help to manage. Is there anything else that you would like to share about the work that you're doing at the U? Like, did we cover it? Is it more expansive than that? Like, what's happening at that center?
Yeah, I think we covered some of the local stuff that I do, but I spend half of my time doing global work. So I travel a lot to different countries. We have partnerships in multiple countries. One of the bigger projects, one of the biggest work that I do is training pelvic floor surgeons in Ethiopia. I've been involved in supporting, urogynecology fellowship training programs in Ethiopia. I was on the board of a large organization that was part of this Worldwide Fistula Fund, and a few other NGOs. And we have university partners in Ethiopia. We have NGO partners in Ethiopia, the Hamlin Fistula Hospital. So this work started back in 2015, and we've graduated 5 fellows from the program, and now we have 2 more who are graduating in April. Actually, I'm going to go for their graduation there. It gives me, so training surgeons there is kind of a gift that keeps on giving, because now they can take care of thousands of women, without us being there, and it's a huge benefit. And then they can serve as local experts for other universities in the country, because urogynecology is very, very nascent there. I mean, our program was one of the first urogyn training programs in the country. So I'm very passionate about building the next generation of healthcare professionals and teaching. That's a passion for me. And we do similar work in Botswana and some other collaborative work. Another project we're working on is on safe C-section. A lot of C-sections are done, especially in countries with low access to obstetric gynecologists, because they don't have enough doctors. They train they train folks to do C-sections on a very much short-term basis. So they could be people who finished their medical school and then did 1 year of internship, where 3 months out of the year is dedicated to learning how to do C-section, for example. But then that may be the only experience they have, and then they become the surgeons in these rural hospitals. The problem with that is it increases the rate of injury and trauma and complications from C-sections, and it raises the rate of maternal mortality. I mean, maternal mortality, one woman dies every 2 minutes in the world from maternal and pregnancy complications, and 94% of those deaths happen in low and middle income countries like Ethiopia, and so these are primarily preventable causes of maternal mortality, kind of similar to this country where, Black women have, 3-4 times higher risk, and Native Americans have that much higher risk. So this project we're working on is how can we use simulation-based educational mixed media education techniques to teach safe C-section. Mm-hmm. And so we've been working with our simulation center and with our partners in Rwanda and Ethiopia to develop some of this simulation educational modules. So that's one of the bigger projects that I'm working on right now.
Yeah. So I'm trying to decide if I'm inspired or because I'm thinking through my own life, right, where I'm jumping from Zoom to Zoom and lunch to lunch, and you're traveling the world, solving these big problems. And I love it. I'm super inspired, but I'm wondering just how are you managing all of this?
Yeah.
It just you just hit your passion and purpose, and it just fills you to the point, because there's a lot of us that are navigating competing priorities or interests that continue to grow, and thinking through how do we effectively manage. You talk about kids, a husband, a new, all these things. How are you managing? What advice do you have for us?
First off, you are doing incredible work. So, Chanda, just what you're doing right now can transform so many lives, right? So don't ever underestimate, the power of communication and what you're doing. I think for me, I work through a community of practice. So I usually, when I pitch an idea for a work or a project, let's solve this problem together, a lot of people get very excited and they want to be part of it, and so then it doesn't become all the work is on me, and people come on board and they're really motivated to do it. I mean, this app project is a very good example. It's actually fulfilling for all of them. They feel so good about being involved. So sometimes, when you're doing something that is deeply meaningful and fulfilling, I feel like it doesn't drain you as much as like paper pushing or, being in a million meetings that doesn't really mean anything or whatever. So part of it is just like figuring out what it is and like then narrowing down on that and saying no to some of these other superficial things. So that's still a work in progress for me, but I would say tapping the wisdom of communities and relying on other people has been my biggest way that I can do more things when I have all the different minds together and everyone is putting in a contribution.
Mm-hmm.
So that's part of it. And then, just taking time to set intentions. I mean, you can see in my background, like I mentioned, this is my meditation room. I try to start my day every day, like 5:30 with a little yoga and meditation. And part of my meditation is setting intention for the day. Like, how do I want to show up? What is important today? Because I may just have today. I may not have tomorrow.
Mm-hmm.
Like kind of setting that mindset. And then like, what is really important today? And that helps you to kind of cut through some of the unimportant things, and then just some gratitude practice and kind of like having that kind of wellness mindset and vision is important, because the reason sometimes that we don't always do the things we want to do is because we are on default, right? We don't even think. We're just always on default. We just like do what's in front of us and we're not thinking. So like taking 5 minutes in the morning to kind of ask that question of like, how do I want to show up? What do I want to accomplish at the end of the day? And what's important today? If I only had today, it kind of reframes everything and then kind of sets you.
The other day I was driving and I was going down a familiar path, but going to a different place.
Yeah.
And next thing I know, I'm like way where, in this automatic place. And I'm like, I didn't even get off.
How did I get here?
How did I get here? Like, how did I get so far beyond where I was supposed to go? Because I was thinking and I was in autopilot. And it had me thinking about, are there other areas in my life where I'm just riding through to a destination without the intentionality? And so that's really helpful. I've been thinking quite a bit about morning, midday, and afternoon practices that allow me to stay intentional with my decisions.
It's so critical, Chanda. I think what you just said, especially like, I think I'm just beginning to realize it now because a lot of bad things did happen in the last 3 years. I mean, which I didn't even mention, loss of a close family member, my brother, my, chronic medical condition that I developed in the last couple of years that makes it very difficult for me sometimes to function. And just that vulnerability, it kind of gave me a little bit more perspective on, prioritizing what's important, including my wellness, right? So it's unfortunate because those things don't need to happen for us to wake up and say that's important. But I think that intentionality is so critical for us to be productive, to be happy, but also to use our time wisely, because we have a lot going on as women, especially. We juggle so much. Yeah.
Yeah, we didn't even get to talk about juggling all of this and while parenting. That's episode next.
That would be another conversation, I guess.
I tell you what. So if the listeners had interest in learning more about your work or the areas that you practice, where would they go?
Yeah, that's a great question. I think for the global health work, our Center for Global Health and Social Responsibility at the University of Minnesota, if they look up our web, if they just type that on our website, a lot of our work is there under Global Women's Health. And I practice out of University M Health Fairview, University of Minnesota for urogynecology. So if they are seeking care or need consultation, that's how they will find me, through the University of Minnesota. I also actually have clinic 1 day a week at the Cook Clinic. I go there one afternoon a month for people who can't come to the university, I go to them. So those are all good places to learn about the work that we're doing.
To explore more insightful conversations and stay updated on Chanda Smith Baker's work, visit smithbaker.co. That's smithbaker.co.